You have a very active, growing older adult population at the intersection of a number of medications and medication use patterns. And that really is what ASCP now represents. So our pharmacists work across the continuum of healthcare. Certainly the backbone is nursing facilities, but we work in assisted living, we work in the community with physicians, all around that medically complex patient or that older adult patient that deals with multiple medications. We're working to make sure that people are on the appropriate amount of needed medications. And sometimes, and a lot of times, that means we're working our way away from certain medications. Certainly, antipsychotic medications are something that's at the forefront of people that work in this industry, and we want solutions that make sure that they're being prescribed and using those medications in an appropriate manner. We want to make sure that any new start antipsychotic of somebody naive to an antipsychotic, that we're doing the right checks for rationale. We have the right diagnosis, and we're treating them appropriately. What we think is a large number of patients are appropriately managed. They're on the antipsychotics for the right reasons. They have a conscientious medical team that's tracking it and following it and making sure they're on the right medications. So we're trying to eliminate those appropriately managed individuals from causing a disadvantage for that nursing facility or a disadvantage for the patient in terms of how a nursing facility or the medical team might approach them. And we have to recognize that, taking care of older adults, medically complex older adults in nursing homes is difficult. The New York Times, picks on an easy target. It's easy to pick on nursing homes. It's difficult to find solutions to the issues that we all agree are probably happening in nursing homes. And I think that's where we need to focus. And I think Project Pause is trying to take that stance that we need improvement and reform. We're not saying that this problem is solved and we need to move on from it. We're saying that we need a better way of looking at it so that we're making sure that the patient is the center of these metrics. It isn't a metric designed to penalize nursing homes. It's a metric designed to improve behavior around patient care.
We really look for gap areas where a lot of the disease specific groups might not be as focused because a particular issue might disproportionately impact older patients. We think that it's important as an organization to look at, what's the landscape, what's happening both within places that CMS covers care and places where they don't cover care. And are there differences and are there things that need to be fixed? And when it comes to Alzheimer's disease and neuropsychiatric symptoms, I think that CMS has been very well-meaning, but I think they've significantly missed the mark over the last 10 years or so in their regulation of psychotropic medications and antipsychotics in particular. We don't have enough research on non-pharmacologic interventions, on ways to redirect folks, on programs that would be useful. And none of us have ever said just use medication and don't use any other strategy. We always believe in doing both to the best of your ability. But folks sometimes get to a point where the non-pharmacologic doesn't help. There's so many pieces to this, but seeing it in this one-dimensional way, dealing with it with a hammer approach as opposed to a scalpel, the way CMS has done over these years, I think it's really aggravated the situation rather than made it better ultimately.